So slightly different subject, all very much still menopause. The women who experience particularly severe genitourinary symptoms, so the women who are experiencing the urgency, the frequency, maybe UTIs, but they're also having the vaginal dryness, soreness, and they're having the vulval symptoms as well. I know that the doses of local estrogen are incredibly small, but one of the things that comes up time and time again is where a woman is already on systemic HRT, so it could be a patch, could be gel. She perhaps has been offered Vagifem, but she's also experiencing vulval symptoms, so she would benefit from using some estriol or some Ovestin cream. Is that safe?
So yes, the short answer is yes. But if you want to go back and say, well, what are the issues? How should we look at this overall? And you look at it and say, the preparations that we have in the UK are all low dose. So if you're looking at the higher dose estriol, if you want to call them, they're all low dose. But if you look at the Ovestin, which is the 500 and the 1000, or if you look at the newer preparations, the Blicel and the Invagis, which are lower. And if you look at the estradiol ones, so if you the Vagirox, the newer one, and the Vagifem, all of these are giving you a low dose that doesn't result in significant systemic absorption. So from that point of view, as you're aware that you can take them indefinitely for symptom control. So from that point of view, they are safe. You don't absorb them in any significant way. And the studies that showed they were safe were done with the doses of 25 micrograms twice a week. So from that point of view, you could say, if you're taking it 3 times a week and you're still having symptoms, it's perfectly reasonable to up it and say, take it about 5 times a week. And with that, you're not absorbing anything significant. But for the group that you referred to, let's say you've done that, you've still got symptoms. So for that group, we would say it would be reasonable to add topical estriol. And I would often say, as a starting point, if you say to me, who would I choose, estradiol tablets first, or would I go with estriol first? I would say it depends on where your symptoms are mainly. So if someone has got deep discomfort and dyspareunia and so on, you would say the estradiol might be helpful. If someone's got vulval symptoms, lower irritation, and around the urethra, you would say the cream would be more beneficial. But there are people who would end up saying you could try both. So a short trial of, let's say, for example, someone's got really significant symptoms where you might say, for a month, take both daily, and beyond the month you could take alternate days, so you could take twice a week Vagifem, twice a week Ovestin, or along. That's perfectly reasonable. And really upping the dose, I mean, especially when you go to the group that you're referring to, if they're on systemic HRT, well, if you end up giving them a higher dose and they absorb a little bit and they're on systemic HRT with progesterone or progestogen, there is no issue there whatsoever. So I would say I would say you be liberal with it. The combination is fine, but also think about alternatives. So now we've got DHEA, so we've got Prasterone available in the UK. It's licensed. So
sorry, can you explain for people very briefly what DHEA actually is?
So DHEA is an androgen precursor. So and of course, as there have been studies that have looked at its role in systemic management of symptoms and libido. That part we haven't got much information, and it hasn't got a clearly defined role. But studies have also looked at the role of DHEA when it's given vaginally for managing urogenital atrophy symptoms. And we've got a licensed product called Prasterone that was licensed in the UK. It's a pessary. Each pessary has 6.5 milligrams. It's applied daily. And we've got good safety data. So the randomized studies that were done looked at it for a year and showed no change in metabolic effects, no change in blood levels. So it's perfectly safe. So I would say from that point of view, if you are taking Vagifem or Ovestin, you're getting ongoing symptoms, you've upped the amount, it's not working, it's reasonable to add DHEA, Prasterone, vaginal pessaries on top. You've also got non-hormonal options that can be added. And again, that's an area I think we often I wouldn't say it's brushed aside and not talked about often. So when you look at the moisturizers, they do have a role. And again, it's relevant that people differentiate between moisturizers and lubricants, because moisturizers are important to rehydrate the tissue. And also, it's also relevant to look at them because some of them have got acidity similar to normal vaginal acidity. So from that point of view, they're maintaining normal vaginal health. And so that's another aspect to consider. So in addition to topical vaginal estrogen, one can consider moisturizers. That'll be another option to consider. There are other options like laser treatment for people who can't take hormones. So let's say when you're referring to the breast cancer patients, that might be an option. It's a relatively new intervention.
Sorry, Haitham, could those breast cancer patients, could they use the topical estrogens because they're such low doses?
So,
or again, is that a one-to-one? Is that an individual consultation?
So you could say, what are the issues in that situation? So you could say, on one hand, you're absorbing very little estrogen, but then you're talking about a group who are sensitive to estrogen. So the answer would be, it depends on the background of the patient.
Yeah.
Because if you have a patient with breast cancer who is taking the aromatase inhibitors, the way that medication works is by almost wiping out your estrogen.
Yeah.
And really, if you follow that concept, you would say you're probably compromising that treatment by giving vaginal estrogen. So that group, you would want to avoid vaginal estrogens. You can say it's less of an issue with tamoxifen because tamoxifen is blocking the estrogen receptors in the breast.
Yeah.
So we would generally say if someone is on tamoxifen, they've got troublesome symptoms, they didn't respond to the moisturizers and the non-hormonal options, we would start them on topical vaginal estrogens, but we would discuss it with their breast team as well.
Yeah.
So from that point of view, we would do it in discussion with the breast team. But if they are on tamoxifen, it's fine. If they're on aromatase inhibitors and they're in a situation where they end up needing it, again, we'll discuss with their breast team. They might end up switching them from aromatase inhibitor to tamoxifen, and then we can add that if the breast team and the oncology team are happy with that, but you wouldn't give it while they're on the aromatase inhibitor. So the risk with it is very small, but a theoretical one, and that's why, again, we would do it with